Thank you very much, and thank you, august audience, for bearing me since yesterday morning. And I'm happy to share my views. And I would urge everybody to become a member of ORCID. This is a very good 16-digit Aadhaar card. You can see my all 110 research work on this ORCID. So this with single digit number, you can have your own work. Recently, I got 2 seats of DNB and 2 seats of ICOG fellowship for reproductive medicine and laparoscopy. The moment child is born, mother is also born. She is there, mother is something new. She is existing, said by Rajyasri. With the blessings of mother of mine and so many mothers, 3 books written by us is recommended in Royal College as a reading material. Like Atlas of Fetal Echocardiography and IVF Made Easy is gone for second edition. I am editor-in-chief of IJOGR and Open Research Journal in Gynecology. Those who want to publish their work, worked as a KOL in diagnostics, and recently I got opportunity to interview Professor Herman Turne in Eshrek, Copenhagen. And this all interview and all intellectual videos you can see on this Manish 4269 YouTube channel. Today the job given to me is laparoscopic anatomy and pelvic floor. Basically, since yesterday we are watching all different videos, but we have to become the first MBBS. In first MBBS, I would see that everybody will like one thing, that is anatomy, because that was the first lecture and we are facilitated by the human body, what are there. So exact knowledge of anatomy of the firm pelvic connective tissue is necessary for gynecological surgeon to avoid blood vessel running within this tissue for during dissection, and particularly when pathology is disturbed. 3 pair of ligaments dividing the 8 potential spaces filled with loose areolar connective tissue, usually devoid of blood and vascular supply. These are the pivocervical, McIntosh, and uterosacral. And this is a Cunningham picture of anterior compartment, middle compartment, and posterior compartment of pelvic anatomy if you viewed from above. But we are laparoscopic surgeons, so we used to go through our scope into the abdomen via umbilicus, because that is technique designed by me in 2005 and written in my books that this is the best technique or natural native open technique. You can go in, you can see this beautiful anatomy inside the pelvic abdomen. If you go from below upwards, first thing comes is pelvic diaphragm. It composed of levator ani and coccygeus muscle. This is the closed inferior outlet of the pelvis. It's supported by the pelvic floor. It elevates the pelvic floor to help the release the feces. Otherwise, all 3 things, urethra, bladder, and rectum, all 3 are lying in parallel, but all 3 sphincters are not acting at the same time. So, pelvic diaphragm is pierced by rectum, urethra, and vagina, and region inferior to pelvic diaphragm is perineum. This is the pelvic floor muscle. This is composed of levator ani and coccygeus, and these are the 3 things which is passing through this pelvic diaphragm. What is the laparoscopic view? First, we will start with sacropromontory. At 7 o'clock, Professor Rivas has started his new near live presentation here, and few delegates are there. And they started with how you have to look at the sacropromontory. These all are the anatomical points. You have to see the uterosacral ligament which is lying over there. Just use very gentle whenever you want to see any anatomy or anything into the pelvic, because everything is magnified. Just remove the bowel, and now you have got very good T-suits available. So you can lift this bowel and you can fix this bowel at the level of anterior abdominal wall, and this is sacral promontory. And always believe that near the sacral promontory, we have to take care of this median sacral vessel and inferior hypoglossal nerve plexus, because if our mesh is sitting on that, then it will cause pain, and sometimes it will cause mesh erosion also. Next step to see in this pelvis, look at the lateral pelvic wall. Here we can see that vessels are going, and these vessels are the external iliac, internal iliac, ureter, and infundibulopelvic ligaments are there. So look at the pelvic wall. Ureter is always guiding you that where all these vessels and anatomy are described. This is infundibulopelvic ligament, external iliac, internal iliac, and your friend ureter is going beautifully. And yesterday Deepak has made ureter dissection like anything everybody has witnessed, and it is an exhaustive surgery, so he was not present even in the program of inauguration. Next, avascular traces. There are the traces are pre-vesical, that is the space of Riccius. Paravesical, it is bilateral, vesicovaginal, rectovaginal, pararectal, and retrorectal spaces. If you see from above, there are 4 spaces lying centrally and 4 spaces lying laterally. So if you, now previously what we are learning in anatomy is from the canina. One laparoscopic anatomy is totally different from the anatomy which we had learned in our textbook. Because this all are talking about this avascular spaces to have a least complication during your surgery. First is pre-vesical space or space of Retius. Since yesterday everybody is doing this dissection of space of Retius. This is anteriorly bounded by pubic bone, posteriorly anterior wall of the bladder, inferiorly pubic symphysis, and it is separated by ascending bladder ligament pilus. What are the important structure lying in this pre-vesical space? Dorsal vein of clitoris, obturator nerve, branch of obturator canal from external iliac artery, dens plexus, nerve of the lower genital tract, and iliopectineal ligament. And yesterday we had seen that people are fixing at the Cooper's ligament and iliopectineal ligament, and this is utmost important in during surgery to the space of Retius. This is the beautiful inferior obliterated umbilical artery. This is bounded by this. If you dissect, you can see very good pubic symphysis, pubic tubercle over there, and here there is ligament of Cooper's and pectineal ligament, and these are the spaces in which we have to do our suspension of burst suspension and paravesical defect of bladder. We can suture it over there. What is the clinical importance? Once you enter in this ligament, you can do variable bladder neck suspension, and you can do same with the open technique, because in residency we used to open, maybe our madam was like to do MMK, that is master mercetic, and that is the very favorite surgery of my teacher Dr. Dr.Manish for SUI, and at that time they are fixing with the periosteum of the pubic symphysis, that is an open SUI technique, and laparoscopic we had witnessed yesterday by Dr. Pandit Kalaskar sir, it is very good. Second is vesicovaginal space. This space between the lower urinary tract and supravaginal septum. Then this space usually we open, and Damodar has very beautifully defined all this bladder dissection. This space is regarding the bladder dissection. You dissect from the medially, you dissect from the laterally, you dissect from the lateral windows, and these are the space we can design. And this is space of Retius, and this is space of paravesical trace, and these all are avascular spaces. If you go very gently over there, and this is the lateral spaces. This is right paracervical, right vesical, and left vesical spaces. You can see beautifully on this, and this is obliterated umbilical artery, vesical pillar, and superior inferior vessels. So these all are the avascular spaces. You can do dissection beautifully, and this is the laparoscopic anatomy. And thank you, Sujal, for giving me this opportunity that I can demonstrate all these things in this endo-ATM conference. What is clinical importance? We can, if there is defect medially or transversely, there is herniation, and that can develop cystosis. Rectovaginal space anteriorly bounded by rectovaginal septum, posteriorly anterior rectal wall, laterally descending pillars, superiorly perineum pouch of Douglas, and inferiorly perineal body 2 to 3 cm above the hymenal ring. It divides pelvis into rectal and urogenital compartment. Anterior rectocele results from this defect on avulsion of septum from the perineal body, and reconstruction of perineum is critical for restoration of important compartment separation. It is supported by anterior vaginal wall, and today morning the Rivasar has dissected the levator ani muscle, and he had directly put mesh over there on that levator ani muscle for the defect. Retrorectal space, boundaries anteriorly by adventitia of the rectum, posteriorly aspect of the sacrum, laterally is communicated with the pararectal spaces, and laterally above the uterosacral ligament and extends superiorly into the presacral spaces. This is the space of retrorectal space. Now we come to the paravesical spaces. These are the paravesical spaces designed by boundary of medially by bladder pillars, laterally by pelvic walls, and supported superiorly by the lateral umbilical ligament. These are the spaces. This is pararectal spaces, boundary by rectal pillars, laterally by levator ani, and posteriorly above the ischial spine. It separates retrorectal spaces by posteriorly extending the descending rectal pillars. This is the anatomy. This is the only simple video, and I narrated, and that's marking is done with paint program. So you can see that these are the spaces. You can visualize all this. There must be good patience on your patient. Before starting any surgery laparoscopically, understand the anatomy, understand the altered physiology, that is pathology, And if you are able to understand all these things, believe me, there is very least complication you can do with laparoscopic surgery, because God has given this anatomy equally to each and everybody. God has not given, because if you see the definition of God, that is GOD, generator, operator, and destroyer. It is given inside Pandora's box, everything remains same. There is no change if you open the Aishwarya Rai abdomen or if you open the abdomen of Champaben or Surendra Nagar, it remains same. So you have to see all this anatomy, particularly all these 8 spaces, and you can do beautiful surgery without complication if your knowledge of anatomy is up to date. Always see, just like Baj, we can see the Sihavalokan or Vihangavalokan here, and in this pararectal space, we can go Okabayasis space and Naslu space, and these are all are avascular spaces. You can dissect it beautifully, see that all spaces are within your vicinity, dissect them properly, have an understanding of anatomy, see all landmarks, everything is bounded by something, so keep into that boundary and do justice to your patients. Thank you very much for patient listening and still stick to the time. Man-made is difficulty because they are necessary to enjoy the success. And happy that dydrogesterone is made by so many companies. And out of 130 company, 86 company using my paper that is published in 2016. Thank you very much. And at the end, everybody should be happy.
Excellent talk by Dr. Manish.
And the place to be happy is here. And the way to be happy is to make someone happy and have a little heaven right here. Thank you very much, ATM team. Thank you, Sujan. Thank you everyone for giving the opportunity. And Buzzer has picked at the right time. Thank you.
On time.
On time.
Thank you, sir. On time. Excellent talk on anatomy of pelvic floor. Any question from audience?